Hi, I have asked Dr. Jeffrey Dash to join me today, and I have been a long time fan of him and his work, and I simply don't know how he manages to do what he's done, the books he's published. I'm going to concentrate on my favorite subject, hormones, as everybody knows. Dr. Dash just recently updated his Bioidentical Hormones 101. And now it's expanded
Oops.
into 3 volumes on Kindle. Is it one volume on the print?
Yeah, well, I chopped it up. First of all, thank you so much for the introduction, Carol. And likewise, I've been a fan of yours for I don't know how long. Uh, so thank you very much for inviting me onto your podcast. I really appreciate it. The problem I had with one of my earlier books is Cracking Cancer Toolkit, which
Yes.
was ended up this gigantic book. It was 3 pounds, 550 pages. And I found out after the fact that I couldn't do an Audible book, which is on Amazon. It's an automatic feature. Just click a box and they turn it into an Audible book. So I got an error message. The book is too big for
Oh,
the
no.
Audible book. So what I did with this book is I chopped it up into 3 volumes for the Audible book, so we could get that feature. And so the 30 chapters, and each volume is 10 chapters. And then the paperback and the hardcover have all 30 chapters.
Okay,
So,
great.
yeah, so it could,
Great. And that's just
yeah.
newly out. That's so good to know. As soon as you had it on Kindle, I was on it. And I would also point out another little Amazon glitch. So I wrote a testimonial for Amazon from my heart.
Oh,
And
thank you so much.
but Amazon rejected me. I broke
Oh,
some sort of community rule. I
yeah,
guess I
I
guess
know.
they
They
don't
do
like
that.
the passion, the heart, whatever.
They have
So
a million little rules, and it's hard to keep up with it because,
so I went to Grok and they said, Grok, please rewrite this
yeah.
with following Amazon rules. And Grok did, and it lost all its heart and soul. But on my website, you'll find the original.
Oh, oh,
And
thank
I'm
you.
going to be including references to it with this. Now, throughout my long career now with bioidentical hormones, there's always two really burning questions. And you really took it on full force. And volume 1 hits it right off the bat. The risk of breast cancer with using hormones. And the second question we can move on to when we exhaust that one is blood clots.
Yeah.
What I really like about your book is I can now it's instead of trying to tackle this enormous subject that I can't really do in a few minutes and I'm totally inadequate, but you have really laid it out in a very logical and useful way. So, do you want to maybe give us a synopsis of what you've written about breast cancer and using bioidentical hormones?
Yes, of course, Carol. The the big study, I think, which is the most convincing, is the 18-year follow-up of the Women's Health Initiative study, which came out in 2017. Dr. Manson uh, was the lead author, and what they found was uh, there were there were two groups. The hormone treated group and then the placebo treated group. There are about 5,000 women in each group. And then there were two separate studies. There was the first arm, which was in which the hormone preparation was Premarin plus medroxyprogesterone for the hormone treated group, and then the placebo group, of course. And then the second study, which was published later in 2004, was the Premarin alone for the hormone treated group. No synthetic progestin, no medroxyprogesterone for that group, and then of course the placebo group. The first arm, which is the synthetic medroxyprogesterone, which will abbreviate as MPA for short, was published in 2002. And of course, that was the huge breast cancer scare that came out in the press. And immediately after that publication in 2002, women stopped using hormone replacement, and doctors stopped ordering hormone replacements, prescribing it. And medical schools stopped teaching it to the medical students.
That's a problem.
Yeah, so this is 20 years later, and we still don't have. We may have a 20-year gap, and we don't have any doctors now. We do have some, obviously, but very few.
Present company excluded.
Yeah, very few in conventional medicine, mainstream medicine, that have the training and background and experience to prescribe bioidentical hormones. So that's been a catastrophe for menopausal women, and it's been causing unnecessary suffering. And you see these types of comments in the current medical literature. So what did the 18-year follow-up show? It showed that the second arm study, which is the women who took Premarin alone, remember Premarin comes from pregnant horses. So it's it's a natural substance it's not human. And many of the estrogens in pregnant horses make are identical to human estrogens, but there's also a whole set of 10 or 20 different estrogens that are called unsaturated B-ring steroids that are not derived from cholesterol. These are found in horses. And it's this whole separate synthesis pathway. And it turns out the B-ring steroids are actually quite beneficial. They preferentially target beta.
I was going to bring that up.
Yeah, which is the
beta being the less stimulatory, less growth involved.
That's the tumor suppressor, right? Exactly. Yep. So,
I was surprised to learn that in your book.
Yeah, I was, and I didn't know that until I if you want to learn something, writing a book will help the writer to learn about the subject. So that's how I learned about it. And it's so getting back to the Women's Health Initiative, the second arm 2004 study, 18-year follow-up, which was, I think, published in 2017 by Marilyn Manson, and or was it Joanne Manson? Joanne Manson. Sorry, Joanne Manson. Maybe that's a different Manson. And it showed a very dramatic 40% reduction in mortality from breast cancer in the Premarin treated group. If I remember the numbers, there were around 41 cases of mortality from breast cancer in the placebo group, and only around 22 in the Premarin treated group. So it didn't quite make 50%. It was like closer to 45%. And it was, for people who love statistics, it was significant, statistically significant. Whereas if you go back to the 2002 study, where they had about a 23% increased breast cancer in the hormone treated group using a different formula. Their formula was Premarin plus medroxyprogesterone. And we know from, lots of other studies that medroxyprogesterone is a carcinogenic endocrine disrupting chemical. It's a synthetic endocrine disrupting chemical.
It used to be a problem way back when.
Yeah.
I started in pharmacy. They used it as a pregnancy test, medroxyprogesterone acetate. I didn't know that. You didn't know that? Oh my God. So they would give a suspected pregnant woman medroxyprogesterone acetate, 10 milligrams daily for 10 days and stop. And theoretically, if you bled, you weren't pregnant. But if you didn't bleed, you were pregnant. And that got eventually stopped because they were causing birth defects.
I can believe it.
With this drug. Shocking, isn't it?
Yeah, I mean, I'm surprised that I would think the HCG test would have been better, but I don't know when that was first developed. But so it turns out that the estrogen treated group here we're dealing with Premarin, had this dramatic reduction in mortality from breast cancer, whereas the first arm, the medroxyprogesterone, which is known to be carcinogenic, had a 23% increased risk for breast cancer. When that was the first arm, it was halted early. After 5.2 years, it was supposed to go for 8 years. So they halted that study early because of the slight increased risk, 23%, which was not statistically significant. There's a whole rigmarole about that. Our current FDA commissioner, Dr. Marty McCary, brought that up in his book, Blind Spots, that, they announced this gigantic announcement creating fear of hormone replacement, and it wasn't even significant, from a statistical point of view. And there are other studies over the years. There are many other studies showing that you can get statistical significance with carcinogenicity. And then the other point that Dr. McCary makes is, they never showed there's not a single study that shows increased mortality from medroxyprogesterone, breast cancer mortality, specifically breast cancer mortality. Not a single study showed us,
oh my gosh.
the studies show increased mortality, but it's not statistically significant, right? So
I like the title of that. If I can deviate a little bit. So we know that there's less stimulation with the estrogen receptor beta. So we know estriol dominates at that receptor site, and so does Premarin. So does testosterone.
Yes,
Actually, so not everybody might know that. Testosterone is extremely protective.
Yes.
But what about estradiol? Now we're talking about mainly alpha receptor now, and the more stimulant effect.
The estradiol is about 50-50, 50% alpha, 50% beta activation. And the testosterone, in addition to one of the major metabolites of testosterone is the 3-beta diol, which again, as you mentioned, preferentially targets beta. But the other important aspect of testosterone is it actually downregulates alpha expression, which so it's sort of a dual effect, sort of the reverse of bisphenol C, which is carcinogenic because it upregulates ERA and downregulates ERB.
Totally. Beta. So when we're talking about estrogen dominant people, we're not measuring for bisphenol A, and it could be a great contributor to too much estrogenic effect.
The Xenoestrogens, they're called Xenoestrogens.
Yeah.
I think that's huge. And the synthetic estrogens in our environment, our good friend and colleague Lindsay Bergson's book, Hormone Deception, was a bestseller on the carcinogenic endocrine disrupting chemicals in the environment, and how to go through your cosmetics and bathroom shower accessories and eliminate all those things. The BPA is lining all the cans. There's BPA in the plastic water bottles and things like that. So that's a huge issue. One of the things that we brought up in the book was, we know that DES, diethylstilbestrol, which is probably the most potent estrogen known, was banned in 1970 because it was causing cancer in the offspring of the mothers given DES. There were millions of pregnant women given DES.
Supposedly to make a good pregnancy even better. What another
that turned out to be a disaster. And so one of the things that was one of the questions raised by authors in the medical literature is, what about all these other endocrine disrupting chemicals? A lot of them are synthetic progestins, like medroxyprogesterone. There's dozens and dozens of them.
Glyphosate glyphosate on everything. It's
The
estrogen.
glyphosate is the Roundup, which
Yep,
is
it's terrible.
sprayed
So we,
on our crops. Of
so
course.
could we,
Let me just finish that thought. So the
okay.
question is, we don't know. We could be seeing further generational effects from these synthetic hormones. And one author raised the question of how perhaps it's affecting the children's uh, neural development, leading to neurodevelopmental disorders,
Yeah. Oh,
which is something mentioned by RFK Jr. As we have this chronic disease epidemic, which involves adults and children. So I'm sorry
yeah,
to
yeah,
interrupt
it's a
you.
big thing. Well, I want to kind of fast forward to what protocol, and you mentioned it several times in your book, have you decided carries a great deal of safety, not only from your research, but from your clinical practice? So if
So
we could go to the nitty
when
gritty.
we're talking about safety, I assume you're talking about breast cancer prevention.
Yes, yeah.
So we devote a lot of pages and real estate in the book to iodine
But
supplementation, which and David Brownstein is a good friend, and he's one of my mentors. Who got me started in integrative medicine because I was working in the hospital as a radiologist for 25, 30 years. And then I had eye trouble, and so I had to retire. This is the eye here. And David Brownstein got me started on a lot of the things that I ended up doing. He was part of the Iodine project, working with Dr. Abraham, who passed away about 12 years ago. But so it turns out that iodine is very breast cancer preventive, and it's also very useful as an adjuvant treatment for breast cancer.
it also is involved in metabolizing estrone over to estriol,
Yes,
weaker. It's key
it's key,
cofactor right
right?
there.
And that study was done by Stoddard, and he looked at the estrogen metabolism influenced by iodine. And what happens is there's a good pathway and a bad pathway. The good pathway leads to methoxyestradiol, which is the anti-cancer drug, and the bad pathway which is the 2-hydroxy pathway, leads to the adduct formation, oxidative byproducts, oxidative byproducts, which still bind to DNA, but they're oxidative and cause oxidative damage. They're supposed to be methylated.
Methylated away, yeah.
And so people with genetic abnormalities in the methylation pathways are at greater risk for breast cancer. And so iodine will shift the metabolism away from the damaging DNA adducts towards the beneficial 2-methoxyestradiol. And estriol is in there. And the benefit of estriol is, of course, that it primarily targets beta. So, and I was discussing this with David Rosensweet, that he recognized right away that I'm a fan of Biased, which is originally formulated by Jonathan Wright, the pioneer, and who started everything, started Bioidentical Hormones. The benefit of the Biased is it's 80% estriol, which is the E3, and it's 20% estradiol. So I think you get all the benefits of Premarin without having to bother a horse.
Yeah,
because estriol is a human hormone. And the other thing that we talk about in terms of breast cancer prevention is the studies and the observations that pregnancy denotes protection from breast cancer. There's like a 70-80% reduction in risk for breast cancer with an early pregnancy. And that was first described by this Italian physician, Bernardo Ramazzini. He noticed that women who had multiple pregnancies, no breast cancer in that group, and women who had no children for whatever reason, they were the ones who he saw breast cancer, which I think it's probably more common in modern era than it was back in the 1700s, early 1700s. And then the other thing that we talk about is just the sheer fact that most breast cancer occurs in the postmenopausal age group. About 80% of breast cancer incidence is in the over 50 age group, whereas only 20% is in the younger women who are having normal menstrual cycles. So if estrogen causes breast cancer, you would expect the opposite. Higher estrogen levels should see more cancer. And then there are animal studies that are very convincing. For example, there's a professor in El Paso, Texas, Texas Tech, by the name of Rajkumar Lakashwamy, and forgive me if I shorten that name a little bit. And he's been working in animal studies, mostly mice, with a number of different mouse models of breast cancer. You have the chemical induced breast cancer, mostly using DMBA, and then you have genetically modified mice to make them more prone to develop cancer. And then then the third model that he used was the injecting human breast cancer cells into mice, the xenograft model. And then what he found was when he gave the mice estrogen progesterone, he found that the hormones were protective, and they had reduced breast cancer activity with the estrogen and progesterone treatment in all three versions of the animal models, and that was very convincing. And then just recently, there's been more interest in women have extremely high hormone levels in pregnancy, and if these high estrogen levels cause breast cancer, then women who have breast cancer should never get pregnant, because that will throw fire on
kill them.
Gasoline, gasoline on the fire. So there's a recent study by Iqbal looking at he looked at a database and he found a large number of women with breast cancer who became pregnant within 6 months of the diagnosis, and he found an 80% reduction in mortality from breast cancer. I think maybe a 60% reduction in recurrence and an 80% reduction in breast cancer mortality in the women who
got
had a pregnancy shortly after being diagnosed. So those are the types of arguments that we present in the book.
Okay. How about, let's just jump over to clotting.
Yes, the clotting.
So deep vein thrombosis, you shouldn't use hormones because you're going to get a thrombus.
And the First Arm Women's Health Initiative study advertised that and made women fearful. And that's one of the adverse side effects of oral estrogen. And you also see it with birth control pills. As a radiologist, one of my jobs was to do the angiograms on young women who had strokes from birth control pills. And it was sad to see young women. They look like movie stars. They look like ballerinas or Hollywood movie actors. These young women, and they have a paralyzed arm or a leg. They've had a stroke from their birth control pills. And so what's causing that? It turns out that oral estrogen is first passed through the liver. The liver then is stimulated to increase clotting factors. The
Okay,
liver makes the clotting factors.
so when you say oral estrogen, are you saying estradiol? Are you saying Premarin? Are you saying both?
Any kind of oral estrogen. It
Okay.
can be Premarin, it can be estradiol. Because of that, we don't use oral estrogen. We use, topical estrogen or vaginal estrogen.
Mhm.
Uh, and there was a researcher who looked at the number of users in the United States of oral estrogen products, and he estimated that if all of these women switched from oral estrogen to topical estrogen, that would prevent between 2,000 and 3,000 strokes every year in the United States. So talk about a public health measure.
Yeah.
That would give you immediate results. Just so I suggested, have the NIH or the FDA mount an advertising campaign,
For sure.
alerting women to switch from oral estrogen to topical estrogen, and that
Yeah.
would be
A huge public benefit. Yeah.
tremendous benefit, just like they did with the ivermectin and "Are You a Horse" campaign, right?
Just
Are you a horse? Don't take
yeah,
ivermectin.
no, that was the negative campaign, or actually
So instead of
trying to
that,
cause
they
more
should do
fear.
something. They should do something
It's a
good.
cause. Yeah, right. They should.
They could save
Uh,
3,000,
Now,
prevent
now
3,000 strokes.
the real big culprit in that clotting stuff is the synthetic progestins. I believe now I can't remember
Yes,
which one you said was the worst
yes.
culprit.
The
The
medroxyprogesterone
medroxyprogesterone is
is
the worst.
also, which is oral, and that's
And
also
and and
culprit.
wasn't norethindrone a pretty high on that list, or not as much?
Uh,
And that's one of the common birth control pills.
Norethindrone
Yeah.
is, I think it's still on the list, but it's not as bad as
It's
medroxy.
okay.
Yeah.
Okay.
The norethisterone was the one that's very popular in Scandinavia. It's used in Finland and Sweden, and that's
Hmm.
the one that the norethisterone was used in the ill-fated habits study, where they gave hormones to breast cancer survivors. That was the only one of 26 studies compiled by Avram Blooming, which
Hmm.
showed increased recurrence, breast cancer recurrence. They used
Wow. Yeah.
the norethisterone, which isn't used much in the U.S. It's mostly medroxyprogesterone in the U.S. But
Okay, so I do
yeah,
want to bring up one more thing. We have
yeah,
this scuttlebutt going on, and I think there's statements by the Endocrine Society, Menopause Society,
yeah.
American College of Obstetrics and Gynecology, and it's that progesterone, if you use it topically, you do not get a good blood level in the serum, and consequently, you can't be sure that the endometrium would be protected.
Uh, I think that's a controversial issue, and we chatted about this before the session. And
Mhm.
the point I brought up was the original FDA approval was based on a randomized controlled trial. I think it was the original manufacturer of Prometrium was
Mhm.
Solvay,
Yep.
and so they showed that oral micronized progesterone would prevent endometrial hyperplasia, and so they received FDA approval on that basis.
Mhm.
But I think you agree with me that we don't have a similar type of study for topical progesterone,
No.
and the
You
absorption.
also brought out the testing technique, which
Yes,
could be RIA radioimmune assay or LC mass spec. And
yes.
you actually can get quite a difference in the report on your test
The
for progesterone.
HPLC is more accurate and gives you more correct readings, whereas the radioimmunoassay, which is the older test, will pick up progesterone metabolites from the oral progesterone and give you a false elevated reading. And we've used the HPLC almost exclusively up until recently, and one of the things that we found was there is quite a bit of whoops. Did you? Hold 1 second. Let me just fix my screen. Okay. There is quite a bit of variation in absorption with topical progesterone. I think it's just due to skin thickness, the different variables involving skin absorption, and
old skin versus young skin, hypothyroid skin.
yeah.
And then how about high adrenaline? When people are so anxious, their adrenaline is high and there's a lot of vasoconstriction, and you've got to get the progesterone into the bloodstream, so the skin circulation isn't very good.
And you do see that on progesterone labs using HPLC. And we've in a very large way switched many of our patients to vaginal hormone preparations, estradiol, progesterone vaginal capsules, vaginal suppositories, which avoids which avoids that problem, because the vaginal mucosa absorption is 2 or 3 times greater than the skin absorption, and we have to reduce. We have to reduce the dosage because of much better absorption.
That's good. That's good to know, because power of the internet or whatever I saw on Facebook, women who have some creams that they have with progesterone doesn't seem to be working as well. They'll freeze their doses so they can use it intravaginally.
Oh, okay. I didn't know that, but that sounds reasonable.
Is that smart? I just love human ingenuity.
I would never have thought of that, but that's how I learn. I learned from my patients. Because we were originally, when we first started 20 years ago with the Bioidentical Hormone Clinic, we were using vaginal creams with an applicator, and then shortly after that, a year or two later, one of my patients called me and said, "What? The vaginal capsule is so much better." I said, "How did you find out?" She said, "I called the pharmacy, and the nice must have been you. The nice pharmacist lady told me about the vaginal capsule." And so then we switched everybody to the vaginal capsule, and everybody's so much happier with that.
Much less messy.
So that's I learned from my patients. I'm not ashamed to admit it. And and we devoted a number of chapters in the book to hormone replacement in breast cancer survivors. So there's a chapter, actually 2 chapters on that, part 1 and part 2. And if you get into the volume 2 and volume 3, you'll get into that material. Also, there's a chapter right after that on adjuvant hormonal treatment of breast cancer with tamoxifen and aromatase inhibitors. And you rely heavily on the material from a Hungarian pathologist in Budapest by the name of Susanna Suba, who's also a geneticist, and she's been writing about this particular topic going back for years and years now, publishing in the medical literature on the pitfalls of anti-estrogens as an adjuvant treatment. And she explains the 3 phases of anti-estrogen resistance. In phase 1, it looks like the treatment is working. There's regression of the tumor. Phase 2, everything's in equilibrium. Phase 3, the tumor becomes resistant and develops into metastatic disease and more patient mortality. So that the main pitfall of anti-estrogen resistance is the patient eventually develops resistance to the treatment and leads to florid metastatic disease. It's not a good thing. One of the reasons why they have a time limit So the treatment for tamoxifen is 5 years, and then then they stop. And I think it's because of they know that eventually the patient will become resistant.
Yeah.
So
not to mention all the suffering from all that hormone depletion.
Yeah, they're miserable. They have severe climacteric symptoms, menopausal symptoms of estrogen deficiency. I mean, they're so miserable, it's palpable. But so it occurred to me that I could use Dr. Suba's concepts that she presents in her writing to explain what happened with the ill-fated habits study in Sweden, where they had increased breast cancer recurrence of 300% in the hormone-treated group. So what happened with their hormone formula, they used, they switched around a lot, but it was mostly estradiol with the norethisterone, the synthetic progestin. And the other important thing that I didn't know, and I learned from our good friend and colleague, Lindsay Bergson, that all of the women who had breast cancer recurrence in the habits study were also taking tamoxifen. So looking at it from that point of view, those are the women who developed tamoxifen resistance, anti-estrogen resistance, which fits right into Dr. Suba's concept of anti-estrogen resistance. And so how do we explain that? Well, the idea is that the breast cancer cells exhaust their ability to compensate. They compensate by upregulating the estrogen receptors and to maintain estrogen signaling. So I theorized, and this is speculation on my part, that when that happens, the testosterone pathway becomes the alternate pathway for estrogen signaling. And I quote, this is in volume 2, chapter 19, and I quoted a number of studies showing that testosterone not only binds to the estrogen receptor elements on DNA, but it also can cause apoptosis of breast cancer cells, similar to with the way estrogen does, which was demonstrated by V. Craig Jordan's work. And so so the cancer cells, in order to continue if they can't upregulate estrogen, then they use testosterone pathways, so what happens when you give a synthetic progestin? It turns out the synthetic progestins are testosterone blocking drugs.
Yeah, that's right.
And so we're now blocking the alternate pathway, and that's according to Dr. Suba's concepts of anti-estrogen resistance. That throws the cancer cells into
it's just a permanent growth situation.
A very bad scenario, and that causes the recurrence, and it's a very high mortality rate when you get a recurrence like that. So that was one of the eureka moments for the book. The little light bulb turned on, and so I wanted to mention that.
I'm glad you put it in. Well, I think we should bring this to a wrap. We probably could be talking all day about hormones. I'm sure I could. I'm sure you could.
It's an endless topic. I agree. That's I think for sure, Carol.
It's been endlessly fascinating and endlessly rewarding, I think. And I'm sure you see that every day as well.
Yeah. So one of the things about the 2 chapters on breast cancer survivors under hormone replacement is actually very beneficial and reduces recurrence unless you're using a bad formula like tamoxifen and a synthetic progestin. So for women and doctors who can avoid the synthetic endocrine disrupting chemical progestins and can avoid the combination of tamoxifen with the progestin, From the bioidentical hormone group, I think will do as well or even better than the great outcome of the progesterone only treated Women's Health Initiative study, which had a 40% reduction in breast cancer mortality compared to placebo. So with that kind of knowledge, women can, breast cancer survivors can feel more comfortable going that route, going the hormone replacement route. And we've actually been seeing more breast cancer survivors since the book came out.
Yeah, I bet.
Yeah.
Okay, I will. I'm going to
Thank you so much.
My newsletter. I really thank you for your time, Dr. Dach.
Thank you so much, Carol. It's always a pleasure working with you, and thank you so much. Over the years, you've been instrumental in so many making connections, and I have to say that I'm very grateful to you for everything you do. Okay,
I'm so grateful for being a part of your books, all of your books, and you asked me for forward. I immediately have to read it, of course. As a result, I can give firsthand testimony. I've read them, and they're great books to have. So I'm going to also supply links for all these things. And thank you so much for today. I really appreciate it. Thank you.
Thank you.